Chapter 15 in your textbook covers autoimmunity. In this chapter, we'll discuss mechanisms of autoimmunity, including immunologic tolerance and genetic and environmental factors involved, systemic autoimmune diseases such as systemic lupus erythematosus, rheumatoid arthritis, granulomatosis with polyangiitis, and the associated laboratory testing of these autoimmune diseases. And we'll cover organ-specific autoimmune diseases and provide examples and associated laboratory testing. Early on, it was noted that the immune system could attack the host that it was supposed to be protecting. So this phenomenon was later known as autoimmune diseases. So these diseases are disorders in which the immune responses are targeted towards self-antigens and in effect result in damage to organs and tissues in the body. The harmful effects can be caused by T-cell mediated immune responses, also known as autoantibodies, that are directed against host antigens. The autoimmune responses can be systemic or organ-specific, and we'll be discussing some of these examples in subsequent slides. Under normal circumstances, the immune system is able to differentiate between self and non-self, or foreign, so that the self-antigens are not destroyed. This is known as self-tolerance, or the ability of the immune system to accept self-antigens and not initiate a response against them. So autoimmune diseases are thought to result from the loss of this self-tolerance. So the concept of self-tolerance is a type of immunologic tolerance or a state of immune unresponsiveness, and it's directed against specific antigen. So in this case, it's self-antigen. So in order for self-tolerance to develop over time, lymphocytes need to be trained so they can distinguish between self and foreign antigens. So this takes place at two different levels, central and peripheral. So this figure is depicting mechanisms of both central and peripheral tolerance. So central tolerance, depicted in this figure in the top left and right, occurs in the thymus and the bone marrow. And this is where the T and B lymphocytes begin to mature. If T cells possess T cell receptors that bind to self-antigen in the thymus, on the left side of this, they're deleted by apoptosis. Alternately, they can then differentiate into T regulator cells that inhibit immune response to self-antigens. If B cells possess B cell receptors that bind strongly to self-antigen in the bone marrow, they are deleted by apoptosis in a process known as negative selection, which we discussed previously. Alternately, they can edit their receptors so they're no longer antigen-specific or downregulate expression of the receptors to become unresponsive to antigen. The self-reactive T and B cells that have escaped to the secondary lymphoid organs, like the lymph nodes and spleen, may be then removed by peripheral tolerance. So this is depicted on the lower left and right sides of the image. Peripheral tolerance of T cells can result from inhibition by T regulators, lack of co-stimulatory signal from an antigen-presenting cell, binding of inhibitory receptors, or death by apoptosis. Self-reactive B cells in the periphery can be deleted by apoptosis or rendered non-functional by repeat stimulation with self-antigens or receipt of inhibitory signals. In some individuals, this central and peripheral tolerance fail to occur, and then this is when autoimmunity results. Autoimmunity is thought to result from complex interactions between both genetic and environmental factors. So inheritance of certain genes may make some individuals more susceptible to a particular autoimmune disease, such as specific HLA types, which can determine the effectiveness of antigen presentation, and MHC genes, which influence development and regulation of immune responses. Exposure of genetically susceptible individuals to endogenous and environmental factors can then trigger autoimmune responses. Hormones can influence autoimmunity, as can be seen that women are almost 3 times as likely to acquire autoimmune diseases as compared to men. Other endogenous or environmental factors that can affect autoimmunity include tissue injury and release of self-antigens, or microbial infections that can trigger autoimmunity in several ways. And lastly, epigenetic factors that cause modifications due to exposure to environmental factors that can alter gene expression may also contribute to autoimmunity. So as was seen on the previous slide, various factors can affect autoimmune development. So gender of the individual, tissue injury, and exposure to infectious organisms or environmental agents are all believed to have significant effects on the immune system that, in effect, trigger autoimmune responses in susceptible individuals. As a result of this break in immunologic tolerance, autoreactive T cells recognize and proliferate in response to self-antigens, and B cells develop into plasma cells that secrete autoantibodies. This can result in the release of pro-inflammatory cytokines, which, when coupled with dysfunctions in the immune regulatory cells, continue the autoimmune response. If these responses are not held in check, they then result in autoimmune disease. There are over 100 autoimmune diseases that have been discovered, and as mentioned previously, they can be directed against a particular organ or involve pathology throughout the body. So examples of some systemic diseases that are involved throughout the body include systemic lupus erythematosus, or lupus, rheumatoid arthritis, and granulomatosis with polyangiitis, also known as Wegener's granulomatosis. Some of the organ-specific autoimmune diseases include autoimmune thyroid, diabetes type 1, celiac disease, autoimmune liver diseases, multiple sclerosis, myasthenia gravis, and then Goodpasture syndrome. The first autoimmune disease we'll discuss is systemic lupus erythematosus, also known as lupus. So this is a chronic systemic inflammatory disease that affects multiple organ systems. It actually affects between 40 and more than 200 persons per 10,000, depending on the population, and the peak onset is usually between 20 and 40 years of age, with women being much more likely to be affected than men. Patients with lupus develop numerous autoantibodies, such as those to double-stranded DNA and other nuclear components, autoantibodies to lymphocytes, red blood cells, and platelets. Immune complexes form, triggering complement activation, chemotaxis of neutrophils, and inflammation. Hypersensitivity was discussed in Chapter 14, but lupus actually exhibits a type 3 hypersensitivity reaction. So the immune complexes that are generated in lupus that activate complement induce the generation of complement 5A, and then this activation of the complement results in the recruitment of neutrophils, which in effect release lysosomal enzymes that cause injury to the surrounding tissue. Environmental factors that play a role in the inflammatory response include UV light, certain medications, and even infectious agents. So exposure to sunlight is a well-known trigger of photosensitive skin rashes seen in many lupus patients, and certain drugs can induce a transient lupus-like syndrome that resolves once the drug is stopped. Clinical symptoms of lupus are diverse, and they vary from patient to patient, but the most commonly affected areas are the joints with arthritis, and skin manifestations occur, such as rashes. The image on the right shows a classic butterfly rash of lupus that covers the nose and cheeks, and this is where lupus derives its name, with it being the Latin word for red wolf. There's renal involvement with kidney inflammation in about half of the patients, and this can lead to renal failure. Other symptoms include pericarditis, tachycardia, and pleuritis, along with anemia, leukopenia, and thrombocytopenia. So as can be seen, the clinical symptoms are diverse, affecting various organ systems and even neurologic symptoms. Various general laboratory tests can be used in the initial evaluation of patients for lupus, including a complete blood count known as a CBC, and this is performed in the hematology lab to determine if the patient presents with leukopenia, thrombocytopenia, and possible anemia. Urinalysis can be done, as we saw that there is renal involvement. C-reactive protein, or CRP, and ESR, the erythrocyte sedimentation rate, which are two different tests that can be done to be indicators of inflammation, and these would be elevated during flare-ups. Complement quantitation can also be done, as complement 3 levels can be decreased during inflammatory flare-ups. One additional laboratory test that's more specific to the serology immunology lab is the ANA, anti-nuclear antibodies. So when lupus is suspected, this is one of the first tests that would be done outside of the routine general laboratory tests, because these anti-nuclear antibodies are present in the majority of patients with the disease.
As mentioned earlier, ANAs, or anti-nuclear antibodies, are autoantibodies that are directed against antigens in the nucleus of mammalian cells, so in humans, and they're present in 95% or greater than 95% of patients with active disease, and they're used as major markers for various autoimmune diseases. Of note, ANAs are not specific for lupus alone, because they can also be detected in a significant percentage of patients with other connective tissue diseases, including mixed connective tissue diseases, Sjogren's syndrome, scleroderma, polymyositis, dermatomyositis, and rheumatoid arthritis. They can also be found in some individuals with other conditions, including chronic infections, cancer, and pregnancy. Anti-nuclear antibodies include anti-dsDNA, which is antibody to double-stranded DNA, and this is one that is lupus-specific, but others include anti-single-stranded DNA, antihistones and nucleosomes, antibodies to centromeres or nucleolar components, and anti-ENA, which is antibody to a small extractable nuclear antigen that are families of small nuclear proteins associated with RNA. Of note, anti-SSA and SSB are associated with neonatal lupus when they're present in the mother and cross the placenta. So these are forms of the anti-ENA. Anti-SM, the Smith antigen, is specific for lupus. It's also important to note, though, that up to 5% of healthy persons and up to 30% of elderly individuals are positive for anti-nuclear antibodies. A variety of methods have been developed to detect ANAs in patient serum. So these methods include indirect immunofluorescence, or IIF, immunoperoxidase staining, enzyme-linked immunosorbent assay, or ELISA, which we've discussed previously, microsphere multiplex immunoassays, or MIA, radioimmunoassays, immunodiffusion, immunoblotting, also known as Western blot, dot blot, immunoelectrophoresis, and microarray methods. Fluorescent anti-nuclear antibody methodology has been the most widely used for anti-nuclear antibody testing. This figure shows an example of fluorescent ANA testing principle, since it is the most widely used and accepted test for ANAs. So with this method, patient serum is incubated with microscope slides fixed with Hep2 cells. A wash step is performed, and then the addition of fluorescent labeled anti-human IgG is added. Another incubation and wash is performed, and then at this stage, the slide is ready to be read under fluorescent microscope. Interpretation of the slides takes technical expertise, as one has to interpret the different patterns observed. So once the slide fluoresces, as seen in figure C, these different patterns need to be identified. The homogeneous pattern at the top, also known as the diffuse pattern, is most commonly associated with lupus specifically. So with this, it's uniform staining of the entire nucleus. This staining pattern can be observed as a result of the antibodies to double-stranded DNA histones, or DNP, seen in lupus. The peripheral pattern, also known as the rim or outline pattern, is another one commonly associated with lupus specifically. The diffuse staining of nucleus with greater intensity around the circles surrounding the nucleus is resulted due to antibodies to double-stranded DNA and is highly specific for lupus. The speckled pattern shows discrete fluorescent specks throughout the nuclei, and this is due to anti-ENA, and it's seen in patients with lupus, but also with other disorders such as scleroderma and other rheumatic autoimmune diseases. The nucleolar pattern shows a few large areas of fluorescence representing the nucleoli within the nuclei, and this is due to antibodies in RNA and RNP, and this is seen in patients mainly with scleroderma. The centromere pattern at the bottom shows numerous discrete speckles in the nuclei of each cell, and this is due to antibodies to proteins in the centromeres of the chromosome, and it's seen mainly in patients with CREST syndrome. Table 15.2 in your textbook provides the common ANA patterns that can be observed. As can be seen on the table, double-stranded DNA or dsDNA antibodies, the homogeneous and/or the peripheral rim pattern on ANA are the most specific Figure 15.5 provides photomicrographs of slides showing 3 patterns of immunofluorescent staining for ANAs. Examples of predominant staining patterns obtained are homogeneous, as seen in the top left image. So the staining of the entire nucleus can be observed. On the right top image is the speckled pattern, so staining throughout the nucleus. And in the bottom shows a microscopic image of the nucleolar pattern, where staining of the nucleolus is observed. Extractable nuclear antigen octolony testing is a method used to determine immunologic specificity of a positive fluorescent antibody test, particularly when a speckled pattern is observed on the anti-nuclear antibodies. This is a principle we discussed previously using diffusion. So here, a mixture of extractable nuclear antigens, including RNP, SM, and other soluble nuclear antigens, is placed in a central well, so the ENA well, and this is on agarose gel. So patient A has anti-SM, because there's identity observed at the wells here. So remember, with this diffusion technique, identity was the smooth curve. Partial identity is observed at the anti-RNP positive control, as can be seen by the straight line and the intersecting line. In this example, patient A has antibody to SM, as can be seen by the arced line. The last antibody to discuss related to lupus is the antiphospholipid antibody. So this is found in approximately 60% of lupus patients, and it's associated with deep vein and arterial thrombosis. In patients with antiphospholipid antibodies, the APTT may be prolonged, and it's not corrected by mixing with normal plasma. Patients with this antibody have increased risk of clotting and spontaneous abortion. Platelet function may also be affected, and thrombocytopenia may be present. In addition to determining the PTT and PT for these patients, there are several enzyme immunoassays for antiphospholipid antibodies that are sensitive and relatively simple to perform. If these antibodies are suspected, factor assays may also need to be performed to rule out any factor deficiencies or factor-specific inhibitors. When antiphospholipid antibodies are present, they can also cause false positive results in non-treponemal tests for syphilis. The lupus anticoagulant is one type of these antiphospholipid antibodies, and this is why the prolonged PTT and PT are observed in these patients. The next autoimmune disease discussed in this chapter is rheumatoid arthritis. So typically, this strikes individuals between the ages of 25 and 55, and women are 3 times as likely to be affected as men. The prevalence of the disease is highest in women who are more than 65 years old. Rheumatoid arthritis is characterized as a chronic, symmetric, and erosive arthritis that causes damage to the peripheral joints and can progress to joint deformity and disability. It can also affect multiple organs, such as the heart and the lungs. Some patients who suffer from rheumatoid arthritis can also develop subcutaneous nodules, pericarditis, so swelling and irritation around the pericardium, interstitial lung disease, or vasculitis, in which the blood vessels become inflamed and thicken and weaken. With rheumatoid arthritis, immune complexes form between autoantibodies produced and self-antigens. So these increase inflammation by causing a type 3 hypersensitivity reaction. Inflammation caused by the disease destroys bone and cartilage. Treatment options for rheumatoid arthritis include administration of NSAIDs, disease-modifying anti-rheumatic drugs such as methotrexate that help reduce inflammation and prevent disease progression, or even the use of biologic agents that target tissue necrosis factors such as monoclonal antibodies against the factor or receptors fused to IgG molecules which bind to circulating factor. Laboratory testing for rheumatoid arthritis includes rheumatoid factor, anti-CCP, anti-nuclear antibodies, SED rate, CRP, and complement testing. So rheumatoid factor can also be found in patients with other connective tissue diseases like lupus, Sjögren's syndrome, scleroderma, and mixed connective tissue disease, as well as some people with chronic infections. Rheumatoid factor assays include latex agglutination, nephelometric methods, ELISA, and chemiluminescence immunoassays. Anti-CCP testing detects an autoantibody directed against cyclic citrullonated peptide, which is a peptide containing a modified arginine. Citrulline is an atypical amino acid that's generated when peptidyl arginine deaminase modifies the amino acid arginine. Anti-CCP assays are performed mainly by ELISA, and they're highly specific for rheumatoid arthritis, whereas the rheumatoid factor, as mentioned before, is actually not necessarily specific, and it's found in about 80% of patients with rheumatoid arthritis, but not necessarily only those with it. Anti-nuclear antibodies are found in about 40% of patients with rheumatoid arthritis and are commonly directed against RNP producing a speckled pattern in the fluorescent anti-nuclear antibody method. Erythrocyte sedimentation rate, C-reactive protein, and complement can be used as general indicators to monitor inflammation in patients with rheumatoid arthritis. Granulomatosis with polyangiitis, also known as Wegener's granulomatosis, is another systemic autoimmune disease that's rare, involving inflammation of small to medium-sized blood vessels and the respiratory tract. This disease progresses to more systemic disease involving other organs. Most patients have antibodies to neutrophil cytoplasmic antigens such as proteinase 3. Neutrophil activation results in damage to vascular endothelium and a T helper 1 response in these patients. Laboratory testing associated with Wegener's granulomatosis include normochromic normocytic anemia, leukocytosis, and eosinophilia in the hematology results, an elevated ESR, decreased serum albumin may be observed. Urinalysis results may show microhematuria, proteinuria, and cellular casts. The patients present with elevated CRP and elevated immunoglobulin levels. Anti-neutrophil cytoplasmic antibodies, also known as ANCA, is another type of test used for autoimmune diseases and is particularly strongly associated with syndromes involving vascular inflammation, such as Wegener's granulomatosis. So with these patients, you'll see positive ANCA, in which it's produced against proteins in the neutrophil granules, these antibodies. So these can be detected by immunofluorescence on an ethanol-fixed leukocytes, ELISA, or chemiluminescent immunoassays. In the indirect immunofluorescence assay for anti-neutrophilic cytoplasmic antibodies, patient serum is incubated with a microscope slide containing ethanol-fixed leukocytes. Following a wash step, a labeled anti-IgG conjugate is added, and after a second incubation and wash, the slide can then be viewed under a fluorescent microscope for fluorescence in the neutrophils. So there's two different fluorescent patterns observed in ANCA testing. The C-ANCA, or cytoplasmic ANCA, which is more specifically associated with GPA, or Wegener's granulomatosis, and then there's the perinuclear pattern, or P-ANCA. So again, patients with GPA produce the C-ANCA pattern, and this is caused by those antibodies to proteinase 3, and it appears as a diffuse granular staining in the neutrophil cytoplasm. In the P-ANCA pattern on the right, fluorescence surrounds the nuclear lobes, bending them together. The antibodies responsible for this are against positively charged antigens such as myeloperoxidase that migrate out of the granules towards the negatively charged nucleus. P-ANCA can appear similar to a peripheral ANA pattern. So far we've been discussing systemic autoimmune diseases, so now we'll touch on some of the organ-specific ones. So the first one is autoimmune thyroid disease. So the thyroid gland is located in the anterior region of the neck and is normally between 12 to 20 grams in size. Normally, the production of hormones T3 and T4 by the thyroid gland is carefully regulated by a feedback loop called the thyroid axis. The hypothalamus secretes thyrotropin-releasing hormone, or THR, which stimulates the pituitary gland to induce the release of TSH, thyroid-stimulating hormone. This then stimulates the thyroid gland to produce the T3 and T4 from the breakdown of thyroglobulin. The enzyme thyroid peroxidase, or TPO, oxidizes iodine ions that are incorporated into thyroglobulin. So if the levels of T3 and T4 become too high, they inhibit the release of TRH and TSH to decrease the thyroid hormone production. So the autoimmune thyroid diseases encompass several clinical conditions, two of them being more well-known: Hashimoto's disease and Graves' disease. So in Graves' disease, autoantibodies to TSH increase thyroid hormone synthesis by bypassing that thyroid axis. In Hashimoto's disease, autoantibodies to TG and TPO lead to decreased thyroid hormone synthesis. Cytotoxic T cells can also damage the thyroid gland. So of the two autoimmune thyroid diseases, Hashimoto's is the most common autoimmune disease. It's mostly seen in middle-aged women. It's also known as chronic lymphocytic thyroiditis, and the disease involves immune destruction of the thyroid gland, producing hypothyroidism. Clinical symptoms include fatigue, dry skin, weight gain, brittle hair, and formation of goiter, which is an enlarged thyroid gland. And in this disease, it feels irregular and rubbery. Laboratory results seen with Hashimoto's disease include normal or high TSH, low free T4, anti-TPO, and anti-TG being present. Anti-TPO, the anti-thyroid peroxidase, is the best indicator of Hashimoto's disease, whereas anti-TG, anti-thyroglobulin, is less sensitive and specific, as they're found in fewer Hashimoto's patients, and it also can be seen in healthy persons as well. Graves' disease is an autoimmune thyroid disease characterized by hyperthyroidism. So this presents most often in women in their 50s and 60s, and it's the most frequently occurring autoimmune disease and the most common cause of hyperthyroidism. Symptoms of Graves' disease include nervousness, weight loss, rapid heartbeat, goiter, and exothalamus. So the goiter in Graves' disease is firm in comparison to the irregular and rubbery characteristic in Hashimoto's disease. Exothalamus is hypertrophy of the eye muscles that causes the eyeballs to appear to bulge out. In Graves' disease, autoantibodies to TSH are produced. So lab results include low TSH and a high free T4, and antibodies to TPO and TG. Type 1 diabetes mellitus is one disorder that actually we've discussed previously that is an autoimmune disease that's organ specific, as it targets the beta cells in the pancreas that results in insulin deficiency. So type 1 diabetes is an endocrine disorder characterized by increased levels of glucose in the blood. The destruction of beta cells occurs through the T helper 1 response, release of cytokines, and inflammation. Autoantibodies affect regulation of pathways needed for insulin secretion. Long-term effects of patients suffering from diabetes type 1 include cardiovascular disease, kidney dysfunction, nerve damage, blindness, and infections. Laboratory results observed with patients with type 1 diabetes include increased glucose blood levels, elevated hemoglobin A1C, which is a glycolylated form of hemoglobin made when the protein combines with glucose. The hemoglobin A1C level correlates with the average plasma glucose concentration over a period of 2 to 3 months prior. Also, autoantibodies to glutamic acid decarboxylase, insuloma antigen, and islet cell antibodies can also be observed in patients with type 1 diabetes. These antibodies can be tested for to confirm a suspected diagnosis of type 1 diabetes in patients who experience elevated glucose and increased hemoglobin A1C levels. Celiac disease is an autoimmune organ-specific disease in which the small intestines is affected. It's triggered by gluten, which is a protein complex found in wheat, barley, and rye. Autoantibodies form in HLA-DQ or HLA-D8 positive people to gliadin, a component of gluten, and deaminated gliadin peptides. These substances are resistant to digestive enzymes in the stomach, pancreas, and small intestines, and undigested gliadin can trigger an autoimmune response if it passes through the epithelial barrier of the intestines. TTG, tissue transglutamase, is an intestinal enzyme that converts the glutamine residues in gliadin to glutamic acid. Endomysium is a layer of connective tissue surrounding the intestinal muscles that autoantibodies can also form against. Symptoms of patients suffering from celiac disease include diarrhea, abdominal pain, and bloating, along with other inflammatory type symptoms. Symptoms also vary with age. Adults and older children or teens may experience some unclassic symptoms such as arthritis, neurologic symptoms, iron deficiency anemia, and skin manifestations. In terms of laboratory testing, detection of IgA antibodies to the tissue transglutamase, TTG, is the screening test of choice because it's highly sensitive and specific for celiac disease. Serologic testing for gliadin antibodies can. Autoimmune liver disease, formerly known as chronic active hepatitis, is categorized into two types, autoimmune hepatitis 1 and 2. These are immune-mediated liver diseases that can lead to end-stage liver failure if untreated. Clinical features include elevated liver enzymes, fatigue, nausea and vomiting, abdominal pain, itchy skin, and jaundice. With autoimmune hepatitis, the hepatocytes are targeted by autoantibodies. With AHI-1, patients are positive for SMA and ANAs. With AHA2, patients are positive for LKM1 or LC1 antibodies. Exposure to certain viruses or drugs have been suggested to play a role in triggering autoimmune hepatitis, possibly through molecular mimicry or cross-reactivity between their epitopes and liver antigens, with the most notable virus being hepatitis C. Primary biliary cirrhosis is another type of autoimmune liver disease that is positive for mitochondrial antibodies, AMAs, in the majority of patients, and in this disease, destruction of the intrahepatic bile ducts occurs. Multiple sclerosis is an autoimmune disorder that involves inflammation and destruction of the central nervous system. Most patients produce antibodies against the myelin basic protein. With multiple sclerosis, plaques form in the white matter of the brain and spinal cord, causing destruction of the myelin sheath of axons. The diagnosis of MS is based primarily on clinical symptoms, demonstration of the disseminated lesions in the white matter of the brain and spinal cord by magnetic resonance imaging. Symptoms of the disease include visual disturbances, weakness in the limbs, dizziness, and sensory abnormalities. Several laboratory tests in combination are used to support the diagnosis, including increased immunoglobulins in spinal fluid and oligoclonal bands on protein electrophoresis of cerebral spinal fluid. Myasthenia gravis is an autoimmune disease that affects the neuromuscular junction, resulting in weak skeletal muscles. It's characterized by weakness and fatigability. Symptoms of patients include drooping of eyelids, double vision, inability to retract the corners of the mouth, muscle weakness, especially in the upper limbs, difficulty speaking and swallowing, inability to support head and trunk, and it can progress to affect respiratory muscles. Most patients have antibodies to acetylcholine receptors. These receptors serve to muscles binding acetylcholine release from nerve endings to cause muscle contraction. Antibodies to the ACH receptors traditionally are detected by radioimmunoprecipitation and more recently by ELISA or fluorescent testing. In the figure on the right, it depicts the mechanism of immunologic injury in myasthenia gravis. So on the center image, figure A, it's showing normal nerve impulse transmission, in which ACH is released from the axon vesicles and binds to the receptor on the postsynaptic membrane, opening the channels, allowing for sodium ions to enter. In figure B, in which the patient is affected by myasthenia gravis, antibodies to the ACH receptors are formed, blocking transmission of the nerve impulses. Again, lab testing used to diagnose this includes detecting the autoantibodies towards the AChR. The last organ-specific autoimmune disorder we'll discuss is Goodpasture syndrome. So in this syndrome, patients produce autoantibodies to basement membranes lining the renal glomeruli and also the lung alveoli. Immune complexes then bind to the basement membranes and attract complement, causing damage by a type 2 hypersensitivity reaction. As we've seen in our urinalysis class, this syndrome can progress to renal failure, and it could also result in respiratory problems such as cough, shortness of breath, and coughing up blood. Laboratory evidence of renal involvement includes gross or microscopic hematuria, proteinuria, a decreased 24-hour creatinine clearance, and elevated blood urea and serum creatinine levels. Abnormally shaped red blood cells and casts can be found in the urine sediment, and in patients with pulmonary involvement, decreased total lung capacity and increased uptake of carbon monoxide is evident. Iron deficiency anemia with decreased hemoglobin and hematocrit can develop if pulmonary hemorrhage is severe. The SED rate and CRP level may be normal or may be increased. Antibodies to the glomerular basement membrane are found in most patients, and this can be detected by indirect immunofluorescence on frozen kidney sections or ELISA for antibody. Tissue-bound anti-glomerular basement membrane detected by direct immunofluorescence on kidney biopsy section produces a smooth, linear ribbon-like fluorescence along the glomerular basement membrane. The major points discussed in this chapter include the concept of autoimmunity resulting from a loss of central or peripheral tolerance, Environmental factors may trigger the development of autoimmune disease in genetically susceptible individuals. Systemic autoimmune diseases include those such as lupus, rheumatoid arthritis, and Wegener's granulomatosis. Most patients with rheumatic autoimmune diseases such as lupus produce anti-nuclear antibodies, and the gold standard in ANA testing is indirect immunofluorescence using Hep2 cells. So remember, there's several major patterns that can be observed with the fluorescence, including homogeneous, peripheral, speckled, nucleolar, and centromere. And these patterns are produced by specific types of ANAs. Rheumatoid factor is an autoantibody directed against the fragment crystallizable portion of IgG, which is found in many RA patients and in many patients with other connective tissue autoimmune disorders. ANCAs are associated with autoimmune syndromes involving vasculitis, and particularly Wegener's granulomatosis, and these produce either a cytoplasmic C-ANCA or perinuclear P-ANCA pattern of fluorescence in indirect immunofluorescence using ethanol-fixed leukocytes. And lastly, the organ-specific autoimmune diseases and their characteristic autoantibodies include those against the liver in autoimmune hepatitis, celiac disease, Goodpasture syndrome, Graves' disease with the thyroid, along with Hashimoto's affecting the thyroid, multiple sclerosis, myasthenia gravis, primary biliary cirrhosis, and then type 1 diabetes.